Thank you very much, Anya, for talking to us about CPR training in the community. I'm now going to talk through a study that was conducted by Dalal Hubail, who unfortunately couldn't be here to present today, validating the use of virtual reality for CPR training. This study was carried out at the Barts Cancer Institute under the guidance of Mr. Vijay Patel. Currently, there are various styles of teaching CPR, often as a one-off, irregular teaching, including instructor-led, feedback devices, peer training schemes, teaching in schools, even flashcards. And as the saying goes, there's an app for everything, so we have to talk about applications here too. This study, however, compares the traditional instructor-led course with the VR compression-only CPR training. There's an ongoing debate about compression-only CPR, and that is what we will look at for the final comparison of the two training methods. So firstly, some problems that can occur with current BLS teaching techniques. We can see from this slide that there are various issues people face when it comes to the traditional CPR training. Important ones to mention here are the limited practice within the training session itself, as well as the time period that occurs between training sessions. Studies have shown that without regular practice, newly learned skills have a tendency to decay in 3 to 6 months. Virtual reality is said to be an important teaching tool of the 21st century. The main feature of this teaching method is the immersive experience of the simulation. It allows the user to be transported to various places, providing a relevant and more realistic learning environment. Benefits of virtual reality in education include unlimited practice, improved learning and retention of the presented material, as well as practical aspects such as education for distance learning and the attraction to a younger demographic. Not to mention, the course itself only takes 15 minutes. We all know from being students ourselves that, our attention spans don't always quite get much further than that, so 15 minutes is very beneficial. It also brings that extra excitement for the younger crowd. So onto the experiment itself. The tested hypothesis was that the VR course will be enjoyable, realistic, and easy to use with comparable skill acquisition to the traditional teaching method when looking at compression-only CPR, while also assessing and validating the use of the VR course as a possible teaching tool. The study was carried out earlier this year, and on the slide we can see the different methods used for recruiting the sample groups. In total, 26 people attended the course. A baseline assessment was carried out, which included checking their current knowledge of BLS using the shown checklist, checking scene safety, were they able to recognize cardiac arrest, did they know to get help, perform chest compressions and ventilations at an appropriate ratio, as well as do everything in the right order. A Lardell QCPR feedback mannequin was also used to assess the quality and ratio of the practical skills, the compressions and the ventilations. The 26 that attended the courses were split randomly into 2 groups, with 13 undertaking the traditional course and 13 doing the VR. Now, the traditional course, as some of you may know, often takes between 3 and 5 hours to complete and includes a variety of other aspects other than the basic 30-2 compressions ventilations. These include the ABCD approach, bleeding, shock. For the VR course, users had a more streamlined experience, focusing on correct emergency protocol, checking the safety of the environment, the patient's responsiveness and breathing, and practice performing compression-only CPR. As mentioned, the course itself takes only 15 minutes and was taught using a headset and hand sensors, as can be seen on the screen. Now, this is a little graphic to show you how the interface works, but Anna will go through that in more detail later. Here we can see just a couple of slides to give you a feel. Check for breathing, and the final results. Okay. After completing their respective courses, participants in the study were assessed again using the same assessments as the baseline, with the assessment checklist and the Lardell QCPR feedback mannequins. This allowed us to examine the educational benefits of each course respectively. As we know, feedback is very important when trialing any new methods in the community, and so the participants in the VR course were also asked to complete the 2 questionnaires I'm going to show you now. This one takes into account the technology-enhanced learning experience, the face and content validation of the material, and finally, both groups were asked to complete a review regarding BLS confidence and concerns. Now, looking at these in a little bit more detail. The first looks at the current use of technology in education and asks whether or not the participant has any experience using these alternative or newer methods. The second questionnaire on face and content validation of the VR course asks users to rate various aspects of the course, including ease of use, usefulness, and the content and experience itself. The final questionnaire asks about BLS confidence and concerns, and here we tried to attempt to understand a bit more about why even trained people hesitate when it comes to performing CPR in a real-life situation. In order to analyse the data, SPSS 23 was used to perform various statistical tests and calculate the mean for the quantitative variables, which were the total checklist, the QCPR results and the questionnaire, as well as the percentages for the categorical variables, the individual steps of the assessment checklist. This slide shows some of the demographic data results. As we can see, 46.2% of the traditional group and 30.8% of the VR group had in fact undertaken previous BLS training with an average of between 2.5 and 3.5 years since their previous courses. We can also see here that the overall age average was in the mid-20s. With regards to the assessment checklist, the mentioned subcategories showed an improvement from the baseline in the traditional instructor-led course. Now you look at this graph as well and you can see again that the improvement seems to be higher in the traditional course. However, this difference was mainly due to the ventilation factor, ventilation ratio, which was not used in the VR course. So after removing these differences in categories and anything not relevant to compression-only CPR and recalculating the p-value for the final assessment, we can see in fact that the results are in fact significant, showing that both teaching methods are similar when it comes to compression-only CPR. The results with the QCPR mannequin told a similar story, and when looking at compression-only CPR, both methods were seen to be equal. When looking at the questionnaires, we can see that a significant percentage of participants had never used virtual reality headsets before in any setting, and that when asked their preferred methods of teaching or learning, along with live demonstrations and hands-on training, technology-enhanced learning, including virtual reality, scored highly. When looking at the face and content validation for the VR group, we can see that participants ranked all categories with an average of between 3 and 5, except the natural feel of the environment. Comparing BLS theory and testing, we can see that both groups conveyed similar knowledge after completing the course, scoring an average of 4 or more. Finally, when analysing BLS concerns and confidence, no major concerns were evident. Most people said that they weren't affected by the fear of contracting a disease or the ethnicity or gender of the victim, but it was more fears about legal liability as well as causing more harm. Finally, most people agreed that knowing the victim would in fact encourage them to start BLS sooner. And BLS confidence was shown to have similar results in both groups. Participants especially enjoyed the audiovisual feedback and appreciated the short time required to complete the course, which gives the chance for repeated practice while staying within the student's attention span. Both features which have been shown to reduce the decay of skills, as well as increase confidence. This learning pyramid shows retention rates of students with different teaching methods, and as we can see, practice, demonstration and audiovisual, which are all key factors of the VR course, show high percentages of retention. So we can see there are many positive features of using VR for BLS training. The immersive learning experience, higher knowledge retention, and the mobility of the device especially means it can be adapted, as Anya mentioned, to expand skills in the community by mass teaching, such as in schools, using this readily available tool for practice. However, always limitations. Limitations of this study in particular included the small sample size, as well as the ongoing development of the course to try and include ventilation. In conclusion, both courses showed an improvement in compression-only CPR skills with positive feedback from VR participants in regards to the ease of use, content and overall experience. Thank you very much for your time.